चलता है? वो छोटा बच्चा है, कभी कभी ऐसा दिख सकता है, आपको महसूस हो सकता है। घबराने की बात है।
अभी राइट हैंड से बहुत पीटता है, लेकिन वो वाला लेफ्ट हैंड से नहीं मारता है। इनका ये कंसर्न है।
आप एक बार इनको नीचे खड़ा करके ऑब्जर्व करें। अगर आपको लगता है कि ये एक ही हाथ यूज कर रहा है, then we have to evaluate in detail. Otherwise,
बट ये करता है सब स्मार्ट
नीचे खड़ा Dr. Jayanth, can you share your screen? नीचे नीचे बैठा अब
Lokesh sir, yeah, joined kada? Right. Thank you, sir.
2 minutes.
Yes, sir. I think all the faculty has joined. Thank you so much. So we'll put this in the WhatsApp groups also. Sir Nitin, sir.
Yes, sir.
Have you posted in the other groups also, sir, to join this link?
Yes, sir. I have posted. I am posting in other group, more groups also.
Yeah.
Yes, sir. I'm joining. I'm asking students. I think, sir, Dr. Jain, kindly.
Yeah, shall we start, sir?
Yes, sir.
Shall we start, sir?
Yes, sir, definitely. Lokesh sir has joined.
Yeah, I'll share the screen.
Yeah, Lokesh Lingappa sir is also there. Yeah.
Yes,
Yes, sir is also there. Right, sir. Thank you, sir. Thank you, sir. Nitin sir, shall we start?
Yes, sir, absolutely. Let's start, sir.
Nitin sir, shall we start?
Can you see my screen?
Yeah, please, Dr. Jain, please share your screen.
Yeah, I have shared.
Yeah, it's visible enough.
Yeah, am I audible clearly?
Yes, you are.
Yeah. So, should I start?
Yes, sir. Welcome all the delegates for this Pac-Man series, which is the Pediatric Acute Care Management series started by Dr. Nitin Chawla, sir, and Dr. Sri Krishna, sir. Pediatric Acute Care Management is a well-sought program across the country. We have 3 WhatsApp groups of more than almost 2,500 pediatricians across the country has joined our group. And they're all going to get at the end the certification course from Royal College of Australia. So with that brief remarks, I would like to invite Dr. Sri Krishna sir, who is the lead coordinator for the Pac-Man series, to give his inaugural remarks and hand over to Dr. Nitin Chawla sir, the course director.
Very good afternoon to everyone. We are sorry for this week. This program is 1 week delayed, as we are doing every time program once in 2 weeks, 2 Fridays, and only this time little bit delayed. As Dr. Pawan told, it's a certificate course offered by the Royal College of Physicians, Australia, and we are having very much interesting discussions from last 3 months. With almost we have finished 7 such sessions. This is the 8th in that series, and today the program. The topic is the movement disorders in children. It is a really wonderful topic and always confusing. However, the expert you are, I think the speaker, Mr. Jayanth Krishna, and expert Dr. Lokesh Lingappa knows that these movement disorders are always confusing topic, and many times we tend to either overshoot or undershoot about this particular topic, and the treatment also the same way it goes in a wrong directions. So it is good that today we have included in this topic, and we have an eminent speakers, Dr. Jayanth Krishna, who is going to speak about the movement disorders in children, and given by the expert opinion by Dr. Lokesh Lingappa. First of all, I thank Dr. Jayanth Krishna and Lokesh Lingappa for accepting this invitation. And the special thanks to Dr. Nitish, Pawan, and TCB President Secretary and Treasurer for accepting to do this program. Without doing much delay, we'll start it.
Thank you so much for the lovely introduction, sir. And I thank Dr. Nitin for the opportunity, and also the team TCB, and also Dr. Pawan and the entire team for giving me an opportunity. And it's my honor and pleasure to be on the side of Dr. Lokesh to talk on this topic. So, as Sir rightly said, movement disorders in children is a pretty exploring and a very challenging topic as such. So, we'll try and understand a few basic concepts and few practical aspects, because I won't be discussing a lot of definitions because they are up in the books and online everywhere. But this lecture is primarily going to be an interactive session. There are going to be a lot of videos, and we'll try to understand and decode each movement disorder that we very commonly face in uh, our practice. So to start, I'll just take quickly the history of this movement disorders. I mean, we have come a long way. Back in 17th century, the doctors didn't even know, or the scientists who were working on the physicians and the pediatricians at that time, nobody actually knew movement disorder originated from basal ganglion. So till the 17th century, Willis was the one who actually put the concept that corpus striatum with basal ganglion was the major seat for motor power and not for movement disorders. So this concept was disregarded by famous.
Sister చెప్తే నీళ్ళు ఇస్తుంది చూడండి ఆ రూమ్ లో కూర్చో ఆ నీళ్ళు మూడు రోజులు ఇస్తుంది వేరే ఎక్కువ కదా 101 102 మంచి
Can you
ఏది తెస్తాం ఈవెంట్
excuse me?
ఇంత జ్వరం ఎక్కువ ఉంటే పిల్లలకి ఫిక్స్ వచ్చి
I request all others to mute your audio type. Please mute yourself so that there won't be any disturbance for the speaker.
Yeah, thank you, sir. Till 17th century, nobody actually knew movement disorders originated from basal ganglion. But I think after the 17th century, so this scientist from Netherlands, his name is Vesalius and Piccolomini. So they distinguish the origin of the movement disorders actually is from the deep nuclei, that is basal ganglion, and not from cortex. So back then there was no neuroimaging, there was no MRI, there was no CT. So only way they could know the pathogenesis of this disease was to follow up that particular disease till the death and do necropsy to see the postmortem changes of that particular disease correlating with that particular organ in the brain. So that was very extensive back then, but still with that limited amount of development, they still could very well localize and understand the pathogenesis that movement disorders actually originate from basal ganglion. And after that, there was very rapid development in the field of neurology. If you see in the 19th centuries, movement disorders was clearly correlated to striatum, that is caudate nucleus, and the other parts of basal ganglion. And Broadbent was the first one who actually uh, came up with the concept that chorea originated from basal ganglion, and atherosis by Hammond. In 1873, Trozov first described the tic disorders, and the Tourette disorder was coined by Gilles Tourette in 1885. And very soon in 1950s, a neuroleptic-induced Parkinsonism, that is a hypokinetic movement disorder, was described in 1950s. And in late 1950s and early 1916, hyperexplexia, this is a pediatric movement disorder, also known as the startle disease, was described for the first time. And pandas, a very controversial movement disorder in children and also in adults, was first described in 1998. This was the last and the latest one which was described in the movement disorder category. And in 1987, the first description of deep brain stimulation being working for movement disorder was described by Ben Abbott. And this was actually a discovery by accident. Like he was actually operating on a patient with Parkinsonism. By mistake, he has actually introduced an electric current into the basal ganglion, and he observed that the tremors decreased. So that is when the concept of DBS came. And 1971, the intrathecal baclofen used for spasticity and dystonia was introduced. So these are the advances which happened in the field in the last 300 years, wherein we had no idea where the movement disorder originated, and now we are in the era wherein we are very much advanced. And you all know after 2000 we have enormous usage of next generation sequencing, that is whole exome sequencing. We have new and new movement disorders which have genetic origin. Like example, if you see primary genetic dystonias have in the last 20 years, it has been an incredible development in this field. And then came precision medicine, because a lot of genetic mutations and genetic dystonias have specific treatment, and they can be used as precision medicine. So this was a quick history. And as I said, Benefit was serendipity, that is discovery by accident. So broadly, I'll just not go into the details of it. The movement disorders can be broadly classified into hyperkinetic movements and hypokinetic movements. Hyperkinetic movements, as the name itself says, there is hyper movement, there is some active movement you can see, in contrast to hypokinetic movements wherein the child is having slow movements or no movements. So our most of our practice in pediatrics is going to be hyperkinetic, because you need to understand the spectrum of movement disorders in children and adult are quite different, because the adult movement disorders most likely originate from Parkinson's and related disorders, and they can be hypokinetic or hyperkinetic with equal incidence, but majority of our pediatric practice revolves around hyperkinetic movements rather than hypokinetic movements. So we'll start with hyperkinetic movement disorder, and then we'll have a quick overview of hypokinetic disorders in the end. So if you see hyperkinetic disorders, they include tremor, myoclonus, chorea, balism, dystonia, athetosis, tics, stereotypies, startle syndromes, ataxia. Ataxia is a controversial thing here. A lot of people not include ataxia as a movement disorder, but some do involve ataxia also as a movement disorder. If you see, the hyperkinetic movement disorders can be easily differentiated based on the quality and the type of the movement, which we call as phenomenology. That is how the movement disorder is actually happening and how is it progressing. So if you have a rhythmic movement disorder, that is most likely a tremor. When you have non-rhythmic movement disorder, if it is sustained and twisting, is dystonia. And if it's slow and snake-like movements, is athetosis. And you have non-rhythmic fast movements, which can be temporarily suppressible, and you have the irresistible urge to do it, that is a tic. When you have a non-suppressible, involuntary, fast, non-rhythmic hyperkinetic movement, that can be asterixis, balismus, chorea, dyskinesia, and myoclonus. Just remember, myoclonus can be both epileptic and also non-epileptic. So the non-epileptic one is the movement disorder. So this I won't go to the definitions of all these because they're easily available, but we'll try to understand the phenomenology with videos. So these are the classical descriptors of the movement disorders which we commonly see. I'll just quickly run into it. The commonest one we see is dystonia. Dystonia is repetitive, sustained, abnormal contracture of posturing of arms because of simultaneous contracture of agonist and antagonist muscles. And they typically have the twisting quality. So that is dystonia. That must be distinguished from spasticity. That is the commonest one we see both in OPD and as well as IPD. That is dystonia. And the second commonest one is tics. Nowadays we see that in the OPD. They are stereotyped, intermittent, sudden, and sometimes it can be suppressible, and you have the irresistible urge to do it. So tics can be complicated. They can be simple. We'll discuss about tics in the later slides. So that's the overall description. And stereotype is something little similar to tics. You have pattern, episodic, repetitive movements which are purposeless. they have associations. We'll discuss that as well. Chorea is described as semi-purposive or involuntary or quasi-purposive repetitive movements across a joint, that is proximal movements usually. And they are usually dancing like a rhythmic movements you see. So they are semi-purposive or quasi-purposive. That is, they try to do it, but they also try to suppress it, and they try to cover it up. We'll see a few videos of that as well. And if you say tremor is, as I described in the previous slide, tremor is rhythmic, only one which is rhythmic. So whenever we have rhythmic oscillation about a central point or a position, that is your tremor. And Parkinsonism, we'll discuss Parkinsonism as a part of hypokinetic movement disorder. As I said, it's not that common in children. So it's a combination of symptoms like bradykinesia or hypokinesia, that is decreased movement, rigidity, or postural instability. That can be accompanied by resting tremor. So these are the basic descriptors. So what do we, as Sir rightly said in the introduction, that it's a common problem in diagnosing movement disorders. Let's go into the details of what are the common challenges we have. If you see, the range of symptoms of movement disorders are very, very complex, and they are in combinations. You see, most of the movement disorders actually go hand in hand. It is very difficult to isolate. You have only dystonia, or there's a component of myoclonus, there is a component of tremor. So it's often a complex combination of disorders. That is one of the common challenge to differentiate what kind of movement disorder is it. And then you have a whole lot of comorbidities. For example, movement disorders can happen in cerebral palsy, it can happen in autoimmune encephalitis, it can happen in a genetic disorder, or it can be happen in any sort of syndromic disorder. Tics are common in autism spectrum disorder. So you'll have combination of various movement disorders happening with a lot of comorbidities. So that is one of the common challenge to delineate and exactly know, is the movement disorder the primary culprit here, or something else is just a additional manifestation of a disorder. And the main issue is that we don't have a clear cut diagnostic criteria. For example, for a lot of neurological disorders, we have a diagnostic criteria set. But with movement disorders, even if you take the diagnosis, the description, and the syndrome diagnosis, we don't have a clear cut unifying diagnostic criteria for most disorders, because that is very variable. Another relative thing, as you see, the pediatric residency is not well focusing. I don't know, it depends on the institute as well. We have limited training in the pediatric residents as a proper movement disorders in pediatrics. We see now and then in the OPD, but we don't have a formal training in pediatric movement disorders. When compared to adult neurology have extensive exposure to movement disorders, what you see in Parkinsonism, etc. And the communication barrier. So why am I saying this? Because in adult, if an adult patient has a movement disorder, he's going to exactly come and describe you what is happening with each and every clear cut descriptor. But it does not happen like that in children. The communication barrier is very significant here. And often, by the time the first time they come to our hospital, these patients are often started on medications. For example, in the OPD practice, we see movement disorder, you randomly add, I mean, it's not to be done, but often they are started on tetrabenazine, they're started on reserpine, clonidine, risperidone, a lot of other drugs which are started, and the phenomenology of that movement disorder changes, and it's very difficult to identify what is the exact movement disorder. That is one of the challenge. And most of the times movement disorders are often treated without identifying the actual diagnosis. For example, if you have dyskinesias or movement disorder dystonia, you just give medication for dystonia, but the underlying disorder, for example, if you have Wilson's disease, if you have any other autoimmune encephalitis that is not being treated, then the movement disorder is obviously going to progress. So these are the common challenges we face. And what are the tips to get over this is basically you should have a systematic approach. Just don't randomly diagnose a movement disorder. You need to have a very close approach. The most crucial thing is try to take as many as home videos from the parents, so you see the exact phenomenology. As I said, movement disorder on a one visit, it's very difficult to identify. You need to see the same pattern of movement disorders happening over time, or is there is a mixture of movement disorders happening, and understand the phenomenology, as I said. And extremely important, as at any neurological disorder, background is very important, like including perinatal history. You have perinatal history of hypoxia, you think of dyskinetic cerebral palsy or dystonic cerebral palsy, something like that. And you have developmental and history is very important, because a lot of genetic disorders are associated with movement disorder. For example, a syndromic autistic child, autism spectrum disorder, ADHD, OCD, all these have overlap with tics and other movement disorders. Family history is again important in the context of genetic dystonias, and metabolic disorders. Medication history extremely important in the context of tardive dyskinesia. So in the concept of acute versus subacute versus chronic is also very important. The onset is extremely important. And when you see a movement disorder, you need to question yourself that is the movement disorder the only disorder, or is it a part of an associated disease? And you need to ask for the associated complaints. For example, neuropsychiatric manifestations is a very common accompanied feature in movement disorder. And then seizures, ask for that, and development delay must be asked. And a thorough clinical examination is extremely important. And there are some movement disorders which get exaggerated with specific maneuvers. They need to be done in clinical examination. And as I said, rational investigations in movement disorder like MRI needs to be done and genetics need to be done. So these are the common tips which we must do to overcome the problems we face in diagnosing a movement disorder. So with this, I think we'll see more. So these are the spectrum of movement disorders. You see, there's a lot of overlap which you see between chorea, myoclonus. Paroxysmal movement disorders will come to that. There is PKD and PNKD, that is paroxysmal kinesiogenic dyskinesia, non-kinesiogenic dyskinesia. Parkinsonism, dystonia, ataxia, there is a significant overlap when you come to genetic disorders. And it is very difficult to delineate one movement disorder. It is often a combination of movement disorders. And with this confusion, another confusion adds here, which is extremely important. You need to be very sure, are you dealing with a seizure? So a movement disorder can sometimes be confused with a seizure and vice versa. If you see on the right side picture, uh, so most of the epilepsy patients, you have a very clear cut seizure being diagnosed as GTCS or a particular type of seizure, and then you diagnose epilepsy. And on the yellow side, if you see in the top, epilepsy mimics. So epilepsy mimics are actually not true epilepsy, but if you see, there are movement disorders which mimic epilepsy, like infantile colic, or like many other things, which hyperexplexia. They are movement disorders. They look like myoclonic seizure or an epilepsy. So you need to be very sure, because if you end up diagnosing that as epilepsy, you'll overtreat with anti-epileptic medications. And there are a few borderline areas. If you see the blue area, borderline, where it's very difficult to differentiate whether it's a seizure or a non-epileptic event. You might have to go for video EEG and other tools to exactly delineate that. And one important thing I would like to focus is the center one, that is epilepsy chameleons. So this is a very interesting entity. These are actually true epilepsies, but they are often misdiagnosed as a movement disorder. For example, if you see G1's syndrome is epilepsy with eyelid myoclonia, it is often misdiagnosed as tics, and it's a very dangerous type of epilepsy wherein you don't treat it, they progress into other type of seizures as well. So G1's is one example. And you also see infantile spasms. Epileptic spasms are often misdiagnosed as infantile colic and sleep myoclonus, because they're happening early in the morning during sleep, so they're often misdiagnosed like that. And even absence seizures are often misdiagnosed as daydreaming and not being attentive and staring spells. So these are few of the epilepsies which actually are epilepsies but are often confused as a non-epileptic event. So you need to differentiate a true epilepsy, epilepsy mimic, epilepsy chameleons, and then try to jump into the movement disorder and then try to delineate which type of movement disorder is it based on the phenomenology of the videos we see. So these are the challenges. I think it is pretty confusing, but I think with more and more information and more videos you see, and with experience, I think you'll be able to master it. So the first step is the approach. Is it truly a movement disorder or not? You need to question this. Second, then classify the movement disorder and which movement disorder is the most prominent thing. For example, if you have identified this child has some dystonia and few components of myoclonus as well, then you try to classify the movement disorder as primary dystonia syndromes with accompanied myoclonus. So you need to figure it out which is the predominant movement disorder phenotype. Third thing is, this is very important. Could this movement disorder be functional? You need to question this, because there are two sides for this. You can't label in the first go as functional, because you're going to miss an organic disorder. So functional needs to be a diagnosis of exclusion. But from the very beginning, with the background and the setup, you can think of functional if there is a clear-cut history. And if you have identified some movement disorder, try to determine the clinical syndrome. For example, you have orofacial dyskinesias and neuropsychiatric behaviors and regression happening in the last 2-3 months. maybe 1 month, then think of autoimmune encephalitis and NMDA. So try to delineate the clinical syndrome. And then next thing you have to remember is that instead of thinking genetic as the first thing, you can think that, are we ruling out, are we trying to miss any acquired causes for this movement disorder? The common acquired causes should never be missed, like SSP, autoimmune encephalitis, and tardive dyskinesia, and drug-induced dyskinesias. The acquired causes needs to be on the top. And does this clinical syndrome fit into a clinical treatable inborn error of metabolism? This is a very important question again. So inborn errors of metabolism, most of them usually the small molecule present within the first 2 years of life with recurrent encephalopathies, and they also can be associated with a movement disorder because the basal ganglion is involved. And then seventh is the point wherein you have ruled out acquired causes, you have ruled out inborn errors of metabolism, and then start considering genetic testing. Even in inborn errors of metabolism, we can do a genetic testing. And after ruling out all the acquired and functional causes, then start thinking of primary genetic movement disorder. In this category, you have genetic dystonia as being common. And then again, after doing your exome sequencing or next gen sequencing, then try to phenotype, reverse phenotype, the particular mutation you have, identify the pathogenic variant or the likely pathogenic variant, and then try to reverse phenotype with the movement disorder you have in the child. So this should be the approach, so that you don't miss any causes of movement disorder. So as I said, a rational investigations, that is the MRI features. So I won't go into the details, but MRI is going to be a very important tool when you have an organic cause of a movement disorder being identified. Predominant basal ganglion involvement can be there in NBI spectrum, Wilson's disease, and a lot of neurometabolic disorders. And I won't go into the detail, even mitochondrial disorders will have a lot of basal ganglion involvement in movement disorder. So MRI is a very important tool in an organic cause of movement disorder. Then in the specific, identifying the specific movement disorder also paves path for identifying the exact etiology. As I said, dystonia localizes to basal ganglion. So you have all these metabolic disorders like mitochondrial cytopathies, organic acidemias, all that are localized to, basal ganglion, that is dystonia. And myoclonus is common in mitochondrial disorders, and sialidosis in Lafora. And chorea is usually acquired, but it can also be seen in inherited disorders like, again, glutaric aciduria, Lesch-Nyhan syndromes. And remember, hypokinetic movement disorders in children is very uncommon. There are a few causes you have to remember. The top one would be Wilson, followed by NBI, that is neuronal brain iron accumulation, and followed by mitochondrial cytopathies. So these are the few types of movement disorders which will try to help you in diagnosing the etiology based on the type of movement disorder you isolate. So very quickly about the pathophysiology, I won't go into the detail. You know that movement disorders primarily originate from basal ganglion, but it's not just purely basal ganglion. But you need to know there's a complex interplay which is happening between the communications between basal ganglion, cortex, thalamus, and even brainstem and cerebellum as well. So the primary game changers in the primary players in this is basal ganglion definitely, but you have inputs coming. The motor origin is coming from cortex, but that movement is being fine tuned by the basal ganglion with the help of thalamic inputs, and also cerebellar pathways also pave path in very well coordination of that movement. So all these, if you see on the left picture, all these are the major game players in the execution of a movement. So whenever something goes wrong in any of these parts, you will have a movement disorder. But primarily, movement disorder will localize to your basal ganglion because they have connections with all these. Sometimes their involvement can also, for example, cerebellar involvement can cause ataxia and other movement disorders as well. So depending on that, but these are the primary parts of pathophysiology you must remember. In the circuit, you have direct and indirect pathway, and this complex interplay, I'm not going to the detail. These are basically, you have inhibitory pathways and excitatory pathways. The major neurotransmitters are glutamate and GABA, the balance of that, and also dopamine. So there's a complex interplay which has each movement disorder which have a different pathogenesis in that. And we'll just go directly into the video. So I think we should all get ready because there'll be a lot of videos now. I think feel free to put your answers in the chat box. So I'll be posting a video. I'll wait for the chat. If I have answers, then we have directly, I'll just skip 10-20 seconds for the each video, and we'll try to discuss why is it that particular movement disorder or not, why do we agree with it or not. So I have a lot of videos which have been consented for, but the consents were obtained for scientific purposes and few research gatherings, but not for a large gathering. So please do not take videographs and photographs for this session. And also the primary consultant and the lead consultants are also tagged in the video. So we'll start with the first case. I'll just be looking at the chat box for answers. So this is the first video. 8-month-old boy, normal development, normal perinatal history, came with these type of movements. I hope the video is playing. You can put your answers in the chat box. Anybody? Hello, sir. Am I audible?
Yeah, you are.
Yeah. So I think we'll all agree with this is a video of a shuddering episodes. So shuddering episodes happen when the child is excited. So you'll have sudden shaking like movements. So shuddering literally means there is a shake. So these are shuddering episodes. They happen. They can happen multiple times a day, multiple times a week. They're usually developmentally normal. They're going to usually come. They're going to subside after 1 or 2 years of age, and they don't need any investigations, no treatment, nothing. The prognosis is excellent. So this is shuddering, a very common entity you see in OPD practice. Coming to the next video, if you know the answer, you can type it in the chat box as well. So this is a child, an infant who has come with a normal development history, but these sort of movements, and the baby has sudden startle-like events when there is a loud noise. And on examination, if you tap on the glabella, there's a myoclonus. So can you name what is this disorder? This is the typical hyperreflexia. I'll just end the video. So on tapping of the glabella, you have that myoclonic startle-like episode. Okay, so this is hyperreflexia. The genetic defect is going to be in your glycine receptors, and you have a specific maneuver to abort these events. Like sudden startling can be avoided by the Biggie maneuver, and they are glycine mediated, though they dramatically respond to clonazepam. So identifying them is going to be extremely important because they're pretty much treatable. Yeah, somebody in the chat box already has said hyperreflexia. Great. Okay, coming to the next video, I'll give you 10 seconds for the video. This is an infant who was presented with developmental arrest. I mean, this child was normal till 6 months, and suddenly the mother noticed that there is not much development after that, and mother noticed that these movements are there since last 2 weeks. Initially, they thought it was cold-induced shivering, but they kept continuing. So just please see the video. You can put your answers in the chat box. I'll play the video again. Okay. Anybody from the chat box? I can try. Okay, this is. Oh, somebody said Korea. No. If you see, these are rhythmic movements. There is rhythmic movements of your perioral region. This is infantile tremor syndrome. So this child, infantile tremor syndrome is developmentally a problematic situation, because once the ITS sets in, you can have developmental arrest, and sometimes you can also have arrest in the pre-ITS stage as well. And this child had a severe B12 deficiency, so you can get the history from the mothers. Usually, mothers will be vegetarian by diet, so a pretty much treatable condition, a common movement disorder in our pediatric practice, and especially in India, it's very pretty common. Okay, another child. Okay, anybody from the chat box? Yeah, somebody said ITS again. Yeah, truly correct. So in the ITS, you can get a typical picture of other manifestations of vitamin B12 as well. So in this, you have knuckle pigmentation, a chubby child, and these manifestations can be usually seen. The knuckle pigmentation is a very important clue for vitamin B12 deficiency. So this child also had ITS. Okay, coming to the next child. This was a 4-year-old girl was brought into the emergency with 1 day history of these abnormal movement, and the child is completely conscious. There's no history of fever. I'll just play the video. Just observe the the phenomenology of this movement. So whenever we try to help the child in sitting from supine to sitting position, this child has this log-like rigidity. She's not able to flex her neck, and she has a stiff spine and the neck region. So in the first instance, you could think about neck stiffness, but as a part of meningeal signs. But this child does not have any altered sensorium, does not have any fever history. Still think of meningitis in this child because sometimes the fever can be missed. But this child, the clue I would give you, this child is not vaccinated. So do you have any clue what we are dealing with? SSP, I don't think so. SSP predominantly presents with myoclonus and neuropsychiatric behavioral disorder, but this log-like rigidity is usually seen in tetanus. So this child had tetanus because this child had history of injury 2 months back, and this child was not vaccinated for any of the vaccines. So tetanus again, it's a very dreadful disorder, but it needs to be identified on time. So log-like rigidity can also be seen in other movement disorders like strychnine poisoning, rigid spine syndrome, but the common ones is tetany. In the Indian setup, it's extremely important because a lot of vaccination is not complete. Okay, coming to the next few videos. Quickly, you can type in the chat box if you have answers. Somebody already answered tetanus. That's good. Okay, the first kid, developmentally normal, is brought to the OPD with these movements. Anybody from there? I think somebody's typing. Uh, Fever, not a mandatory criteria for tetanus. No, tetanus, there's no extra fever. Usually, we can have. Okay, anybody with this video? This can be classified as tics, or sometimes it can be classified as stereotypic movements as well. Yeah, ocular tics. Somebody answered correct. Yeah, we can classify it. So, coming to the next video. This child again developmentally normal, past history normal, perennial history is normal. Has these type of movement disorder, especially when you actually start taking the video, he has these movements more often. Anybody? I'll play the video again. Somebody said tics. Yeah, this is also tics. Okay. Okay. The third video, I need your answers with this. So this child is developmentally normal again. These sort of movements since last 2 weeks. Multiple episodes per day. Sensorium is normal. During these episodes, the child is able to answer. He's conscious and aware. Okay. Anybody? I'll take 10 minutes for the answer too. Okay, so this is not a movement disorder. This is a focal seizure. Somebody answered. No, no tics. These are not tics. That's why I placed this with this movement disorder. Whenever you're diagnosing movement disorder, you need to be extremely sure that you're not missing a seizure. This is a focal aware seizure. This child had neurocystic psychosis. So this is left focal aware seizure. You see that the facial deviation, the angle of mouth, eye twitching, these are classical features of seizure. Okay, a little bit about tic disorder. If you have tics, as I said, tics are involuntary, semi resistible. You have the urge to do it, and the repetitive movements. Oh, somebody asked to play the video. 1 second. The third video, is it playing? Okay, one more time. Yeah. Okay. Yeah. So regarding just a little bit of tick disorders can be, transient. If there's a tick, you need to identify it's a motor tick or a vocal tick, and the duration of the ticks. If the tick duration is more than 1 year, you can call it a tick disorder. or a chronic tic disorder. If it's less than 1 year, the term which is used is called transient tic disorder. But when you have a combination of motor tics and vocal tics and lasting more than 1 year, you can classify that as Tourette disorder or Tourette syndrome. And a little bit about the pathogenesis. It's very complex. Nobody actually knows where is the origin of tic, but this is the probable hypothesis wherein the premotor cortex is the tic generator and frontal lobe is the tic suppressor. So there's an imbalance between these two areas and that produces tics. And tics are very often associated with other movement disorders and other comorbidities, like very commonly seen in developmental delay, autism spectrum disorder, Asperger's. I mean, even ADHD children have tic disorder, and it's a part of pandas as well. So a very common association. And as you know, HK movie was based on that. She had Tourette because she had both vocal and motor tics. Okay, coming to the next video, I'll need answers here. So this child actually, an interesting child, was 7 year old, was brought in with these sort of movements. And with these movements, the family actually took the child to a temple, thinking it was a demonic possession. And after 10 days of temple stay, they came to our OPD. You can see the movements closely. Anybody from the chat box can answer this? Okay, somebody answered Korea. Yeah, Korea, a lot of Koreas. Yeah, it is Korea. And you see the try to describe this. These are semi-purposive, quasi-purposive. She's trying to, cover up her movement. She's having an involuntary movement. She's at the same time trying to, hold a dress or try to set her hair. So she's trying to covering up that. No, she's embarrassed with the fact that she's having some movement disorder. She's also trying to cover it up. So this is semi-purposive or quasi-purposive. Involuntary rhythmic movements, which is happening more pronounced in the proximal joints. So you can also see lip smacking movements. This is a very classical chorea. So the most common cause of chorea in India would be Sydenham's chorea until and unless you rule it out. So that's the most commonest cause. So this is another video of the child. You can see the very predominant perioral movements, the tongue thrusting movements, lip smacking, and very severe coriform movements both in upper limbs as well as lower limbs. Okay, and this child on examination had slight tenderness in the left ankle, and there's history of ankle pains in the last 2 months. And on echocardiography, there was mitral valvulitis. So this was actually a classical case of Sydenham's chorea with acute rheumatic fever. And after treatment with steroids and haloperidol, this was after 3 days. I'll just play the third video 1 second. She improved pretty significantly. So in the treatment of chorea, you can choose valproate or haloperidol. And as you know, it's an autoimmune phenomenon. I think you can give steroids as well. IV versus oral is a controversy, but steroids actually help in the treatment of Sydenham's chorea. And you need to give penicillin prophylaxis for the rest of the management. This was a classical case of chorea, Sydenham's chorea. Okay, so a little bit about this entity that Sydenham's chorea is now included as a part of PANDAS. PANDAS is pediatric autoimmune neuropsychiatric manifestations associated with streptococcal infection. And there's a very close entity which is pediatric autoimmune neuropsychiatric manifestation, neuropsychiatric syndrome, but not associated with streptococcal infection. So these two have a very common type of symptoms wherein you have OCDs, tics, and neuropsychiatric manifestations like sleep disturbances, lack of concentration. They are very pretty non-specific, and it can only be emotional lability and depression as well. But as you know, pandas is a controversial entity. A lot of people in the world, a lot of standard organizations do not consider this actual diagnosis. It's like a wastebasket diagnosis, but the controversy still goes on. Some people really think that it's there. Some people think it's just a label which can be given to any undiagnosed disorder. But pandas, I think you need to consider pandas after ruling out everything. So that would be the better one. Do not consider pandas in the first go. Okay, coming to the next video. Can you see this? This child had mild developmental delay. He was around 12 months, but he could only sit with support. but not crawling and not standing with support yet. On examination, this child had mild dysmorphism with prominent, there's subtle synorphis as well, and also these movements along. Can you classify this type of movement disorder? I mean, what do you put this in? This is not myoclonus. These are slow movements. These are head rocking movements. So this can be classified as a stereotypy. So stereotyped movement disorder can be there in a lot of genetic disorder, autism spectrum disorder, and a lot of other conditions. Another movement. Can you see the video? Is it playing? Is the video playing? Yeah, I guess. Anybody? What is this movement disorder? Somebody answered dystonia. No, he's trying to rock his body. So this is a type of stereotypy. So stereotypy is a type of movement disorder when you have repetitive, purposeless movements, which are often associated with a comorbidity like developmental delay, cerebral palsy, autism spectrum disorder. So the different type of stereotypy. So on the right side, if you see, this is the body rocking type of stereotypy. On the left side, you see this is the head moving or head shaking type of stereotypies. Okay, so this is a different movement disorder: shaking hands, waving the body rocking, or head banging, hitting himself. All these, there are different type of stereotypic movements which can be complex or simple. Okay, that video was not continuous. I agree. There's some glitch. Yeah, I think it's playing now. Yeah, again, there's a problem. I think. Okay, I'll show that later. Okay, another child. So this is an 11-year-old child with a confirmed diagnosis. I'll tell the diagnosis later on, but this child has severe developmental delay and regression and seizures with this movement disorder. If you see in this video, this child has episodes of hyperventilation, and also you see that this midline stereotype is whenever this child has a movement disorder, both their hands come in the midline and they try to do that. So these are midline stereotypies, and there's also facial dystonia. I see that. And in the initial phase, we thought it was focal seizures, but the event did not have any ictal correlate. And the second video you see, it actually looked like focal seizures, but this did not have any video correlate. You also see midline stereotypies and facial dystonia, and you also see there's expressionless face. So there's a combination of movement disorder here. So there is dystonia, there is stereotypies, especially when I'm talking about midline stereotypies, what comes into your mind? Midline stereotypies are a characteristic feature of Rett syndrome. So this is a known case of MECP2 pathogenic variant of a classical Rett syndrome. So remember, Rett syndrome will have a very florid movement disorder, like especially midline stereotypies, dystonia, seizures, all of it. Okay, coming to the next one, very common ICU thing. This 11-year-old female came to our ICU with one day history of these movements. Her consciousness has come down. She's not completely oriented. She's confused. And she has this severe movement disorder wherein she arches to her side. Even if you see her legs, they're tied up. There's this severe arching of the back and also posturing of the legs and hands. So, what is the movement disorder? Where do you classify this? This is not tetanus, but let's not go to the diagnosis. Try to identify which type of movement disorder is it. How do you classify this? There's sustained contraction of muscles at different parts of the body, which is causing postural problems. So how do you classify this? You classify it as dystonia, right? So let's go by the diagnosis later on, but try to identify the movement disorder. So this is predominantly dystonia. Yeah, somebody answered dystonia. 11-year-old coming to you with sudden onset dystonia, acute onset dystonia. So this child actually went into status dystonicus. So we need to give a lot of medications, and still the dystonia was not coming down. We had to give intravenous benzodiazepine, a lot of other medications. So whenever you have a child with status dystonicus coming to you, you need to manage them very aggressively because it's an emergency. Because we have dystonia, which is going on for more than 24 hours. It can be called as dystonic storm or status dystonicus, and that can cause other problems like rhabdomyolysis, CKD, etc. So this child eventually ended up having Wilson's disease. We had worked up for Wilson's disease. So one of the presentations of Wilson's disorder is a predominant movement disorder, even before the onset of behavioral problems. So that child ended up having Wilson's. So I'll play the second video. A 8-month-old child with these movements was admitted to the ICU, and these movements kept happening persistently, and the child was escalated on the anti-seizure medications elsewhere. How do you classify this? Seizures. Okay, that's what the child was treated for. Seizures, yeah, you can consider, but if you see, these movements had posturing like movement. See the legs, that there's crossing of legs. So this is dystonia. Somebody answer it. Kridushat, no. So this is a typical dystonia wherein this twisting posture, this crossing over legs, and this child has a cry whenever he's irritated. He has intermittent episodes of dystonic episodes, and this was falsely treated as seizures, and eventually, worked up. If you also see, this child has periorbital puffiness. On echocardiography, this child also had dilated cardiomyopathy. Somebody answered dystonia, correct? So dilated cardiomyopathy, heart issues, and dystonia. Always think of a condition which is called biotin thiamine responsive basal ganglion disease. Is a very common disease in India, in specific parts of Telangana, wherein pregnancy, the diet is completely different. There's a few sects of religions and a few sects of people who do not consume non-vegetarian and specific foods in pregnancy, and the mothers are severely deficient in biotin and thiamine, and the child is exclusively breastfed, and the child will have very severe deficiency of biotin and thiamine. And so looking at this MRI picture, you would send genetics, whole exome sequencing, and mitochondrial. Everything is going to come back negative because this is an acquired condition. With this thiamine deficiency, you have cardiomyopathy, and this biotin and thiamine deficiency causes this peculiar basal ganglion pattern in the MRI, and they present with severe dystonia, causing dystonic storm. So all that you have to do is to start supplement biotin and thiamine. They'll slowly recover, but not completely. You can have some sequelae as well. So this is dystonia again. Okay, this a very interesting case. This is a 9-year-old boy who has come with 2 weeks history of emotional lability. He started crying in the class in the school without any reason. Somehow there was no reason, that nobody actually scolded him, but he was very sad and he was crying to a point that parents were concerned. And along with this, his speech also has changed. So these complaints, the child has come. Observe this child. पापा का नाम बताओ. पापा का नाम पूरा नाम. मम्मी का. ठीक है. दांत दिखाओ के. ठीक है. Can you identify what type of movement disorder is this? Okay, let's try to classify what is this. No. No, no, let's not go into the diagnosis. Pandas, no. Let's try to identify. Is it chorea? Is it dystonia? Is it tremor? What is it? Let's try to identify the movement disorder and then come to diagnosis later on. Somebody said facial dystonia. Excellent. So you see there is dystonic hemidystonia on the left side. Definitely there's facial dystonia. And apart from that, do you see anything else? This dystonia is very prominent around the perioral region and the lips region whenever he talks also. And also notice the speech. The speech is not normal. This is not. So this is spastic speech or dysarthric speech, spastic dysarthria. So when you have such type of presentations, a dystonia localizes to your basal ganglion, and spastic speech localizes to your adonicus. So this can be seen in a lot of other conditions like poisonings and all, but Yeah. Am I audible now?
Yes,
Yeah.
but no video.
Yeah. I'm just sharing. The meeting had to end because there was only 45 minutes for that. So I'm just rejoining it. Can you see my screen now? Hello.
Yes, yes.
Yeah. Okay. One second. Yeah. So am I audible as well?
Yeah,
Yeah. One second. I'll just connect. Yeah. I think everybody can hear. So this was a case of the classical Wilson's disease, presenting with facial dystonia and spastic speech. And in this context, I would also like to introduce you to this very interesting topic, which is ion accumulation in the brain. This is called NBIA spectrum. There's neuronal brain ion accumulation. So the very spectrum, this entity is extremely important in this context because they have florid movement disorder. They have dystonia, they have acidosis, they have rigidity, they have Parkinsonism. If you see on the right, there's a poster which is called complete bending poster. This is called camptocormia, a very classical sign in NBI. So they have a very florid and a severe sort of movement disorder in this particular entity. And some of them have late onset, some of them have early onset. In the children, you see PLAN mutation often happens in the first 5 years, and BPAN and MPAN can happen in the adolescence, and PCAN usually happens, after adolescence and in adulthood. The rest of the diseases happen in the late age. But do remember, a florid movement disorder, start thinking about NBI as well after Wilson's disease, because they have MRI differences. You have T2 hypointensities, that is iron deposition, can be seen in the MRI. So this was another child on the left. If you see, this is a child with molybdenum cofactor deficiency with predominant basal ganglion involvement. This is complete opistotonic or arching of posture. So this is a florid movement disorder. As I said, status dystonicus is a medical emergency. You need to treat it very early. This is an ICU admission. You have to look for all the other parameters, hemodynamics. Sedation is extremely important because any noise, any painful stimulus is going to stimulate the dystonia and is going to increase the dystonic storm. You need to use paralytics, you need to use intravenous benzodiazepines to control it. And sometimes you need to consider intrathecal baclofen as well. So this one picture, I'll just quickly go. This is very important. I had a child with a movement disorder, and that child had a 7-month-old child with a very non-specific movement disorder. It looked like myoclonic, sleep myoclonus to me. But on examination, this child had the father had this expressionless face. So this, I'm presenting it because it's very important not only to examine the child, also to examine the parents. So this child had a very slow movements, and when I asked him to smile, this was a very slow or a expressionless face. So, and I have referred this child to the adult neurologist. Dr. Abhinay actually has diagnosed this child with young onset Parkinson's with the help of PET. So examining this father is also very important because the carriers of Gaucher's disease can also are prone to have Parkinson's, young onset Parkinson's especially. So the GBA mutation is a known entity in young onset Parkinson's. Okay, coming to the next video, I think you need to identify not the diagnosis, just tell me what is the movement disorder you see. You see what is happening? Can anybody name what is this? What kind of a movement disorder is it in the chat? Somebody says athetosis. Not exactly. See, this child has a very severe sort of neck posture, abnormal, involuntary, sustained contraction of the neck muscles, this upper limb, proximal upper limb predominantly. So this is very classical dystonia. So dystonic posturing here. So on walking also, if you see, there is the right hand being dystonic, going into dystonic posturing, and is also dragging the left leg. And there's some amount of myoclonic component to it as well. So this is a complex dystonia. So the predominant movement disorder in this would be dystonia. And the history of this patient, these movements are there since last 1 year, and they're slowly increasing. Since the last 2 months, it were very concerning. So the patient has come here for that. So no history of behavioral problems, no history of regression, no history of fever, no history of other movement disorders. His rest examination is completely normal. So yeah, somebody said it's a mixed pattern dystonia. So whenever we have a chronic onset, this age, other examination being normal, no behavioral manifestations, no regression, start thinking about primary genetic dystonias. So that's a not a common entity, but I think you need to think about it because there are different types. With now the emerging with the help of next generation sequencing, we have a lot of genetic dystonias being identified. There are various types with specific phenotype and genotype correlation. So a genetic testing in this particular type of in this particular type of movement disorder is very, very important because some of them have precision medicine. Like for example, PRRT mutation, which causes PKD, when they respond very dramatically to carbamazepine. So rest of the dystonias do respond to gabapentin, but not completely. In these patients eventually become drug resistant and they need surgeries like DBS and intrathecal baclofen pump.
Dr.
So this
Jayanth,
is
5 more minutes, please.
pardon.
5 more minutes.
Okay, I'll go fast. So these are some of the genetic causes of dystonias, genetic disorders. I won't go into the detail. A very interesting case. This is another child who has come with history of 2 weeks of these movements. You see, these movements have involuntary contraction-like movements of the abdomen. I don't know whether to classify this primarily as a movement disorder, but this was his only presentation. Multiple episodes, even 100 to 200 episodes. So sometimes these movements had hiccups. So somebody said abdominal epilepsy, not exactly, not the sensorium, everything is normal. I did consider EEG and EEG was normal, but these movement had abdominal contractions like hiccup-like movement, but not hiccups. So these are actually intractable hiccups. Hiccups may not be the classical, the sound which produces, but the entire abdominal contraction and the diaphragm movement was there. And whenever we have intractable hiccups, the first thing you start thinking about a drug induce. A lot of antibiotics which can cause. This child was on nitrofurantoin for 2 weeks, and after nitrofurantoin, these movements started. And after stopping nitrofurantoin, these movements actually, when he came, he was on the treatment for UTI, a chronic UTI. So he was on the 9th day, but I changed nitrofurantoin to cefixime. Then his movement stopped within 3 days. So I didn't start any medications. So sometimes with intractable hiccups, you can actually treat them with baclofen also. So these were intractable hiccups. Okay, this I won't. I'll just quickly go. This is a very rare condition wherein you have tremor-like movements of your chin. So this is called hereditary chin tremor or geniospasm. So we recently published this in BMJ, and it's a very rare entity, autosomal dominant, highly penetrant, very benign condition. Another interesting video, I think I'll need inputs from here. This child had these movements since 6 months, and this child roamed about everywhere with every dermatologist, considering it is some pruritic condition. So whenever the entire day he does this, no other manifestations, no neuroregression, no psychiatric manifestations. Everything else is fine. If you closely see, this child not only has, no, he's trying to show that he has itching actually, but none of the dermatologists could identify actually a pathology. He was on a lot of antihistaminics, even on steroids for undiagnosed pruritic condition. But these, if you see, he has subtle coriform movements as well. So whenever he's itching, he's also having involuntary movement of his left leg. So very subtle coriform movements. Unfortunately, we couldn't evaluate this child. This child never came back. So I was thinking about coriform movements in this particular disorder. I think I'll have to take opinion from Dr. Lokesh as well. Okay, coming to the next video, I'll quickly go. Anybody? So definitely not a seizure, definitely not a movement disorder. It's a functional movement disorder. So you can clearly say that person is saying Om Cream Pat Swaha. It's an effect of Telugu movie. So, and we also see other movement disorders. So see, these are typical non-epileptic events. Asynchronous movements, no pattern. Whenever you try to take a video, he has more movements. And he had a history of not going to school. He doesn't want to go to school. And he gives a very good concept. There's no point going to the school because a lot of reasons. See, these are typical functional neurological disorders. So the term pseudo seizures, the term, all these are not used anymore. So this is another video. This child has these episodes. The moment you put nasal normal saline spray, and the movement is gone. This again functional neurological disorder, FND. This child again, episodes of these fainting, especially when you take videos and you have more severe or more frequent episodes. Again, she doesn't want to school. So this is another functional disorder. So sometimes this child has vocal tics also, and a history of behavioral manifestations. So we have evaluated this child for autoimmune encephalitis and other organic causes, KF-ring, but everything came back negative. So this was a primary functional disorder or a psychiatric disorder, because this child also had behavioral problems. I'll just take 3 more minutes up. Another functional disorder. We have evaluated this child and nothing came up. So one thing, whenever you have functional neurological disorders and acute onset movement disorder, also think of recreational drug use, because that has been common now in adolescents, male, not only males, everybody. I mean, a lot of recreational drugs. So whenever you have a suspicion of an event which happened in the night, or some party being there, a group of people going around, do get a tox screen, because a lot of drugs can cause this. Especially marijuana can cause these sort of movement disorders and behavioral problems. This child has behavioral issues and movement disorder. So do not use it. Quickly about FND. FND is a latest term which is introduced. I mean, this is the most accepted the terminology which is used. Previously, the pseudo seizure, conversion disorder, hysteria, psychogenic, medically unexplained symptoms, psychogenic, psychosomatic, all these are not used anymore. I'll just skip this. Not to miss any true seizure, this child had a myoclonus head drop. This is a myoclonus, not to misdiagnose a movement disorder. I'll skip this. Okay, one last video for this. Very interesting case. This child, 18 or 16-year-old girl, came with behavioral problems, extreme emotional lability, and this movement disorder. Anybody? Somebody correctly said catatonia. That's an excellent pick. So this is a typical feature of catatonia. This is called waxy flexibility. Whenever you put a patient in particular posture, they'll be in that particular posture only. So this is the typical posture. What you see, this child had this. This is catatonia. The manifestation being waxy flexibility. So catatonia can be organic or non-organic. In the organic, you have to definitely rule out autoimmune encephalitis. And functionally, it's a part of schizophrenia, a primary psychiatric disorder. Surprisingly, this patient had NMDA receptor positive. This child responded completely to steroids, because this child also had behavioral problems. We had autoimmune encephalitis at the first TD, and this child had NMDA positive. This is a typical course. I won't go into the detail. The typical course would be a viral prodrome followed by psychiatric manifestations and then movement disorder. The typical movement disorder on the right, which is depicted, is perioral dyskinesia or orofacial dyskinesia, a very characteristic feature of NMDA receptor antibodies. Okay, one more video. This child had these sort of movements, closely observed, and tried to tell us what type of movement is this. What do you see? So whenever she's talking, suddenly she protrudes her tongue. So this is happening multiple times per day, and since last two weeks. So this is a very characteristic feature of tardive dyskinesia. This is called the tongue protrusion. So this is a feature of tardive dyskinesia. Tardive dyskinesia definitely take history of drugs. So in the tardive dyskinesia, you can have tongue protrusion, lip smacking, mouth puckering, facial grimacing. All these movements can happen. But unfortunately, with all the history we got, this child, we couldn't identify what the drug was. But eventually, this child recovered. So tardive itself means delayed symptoms. Dyskinesia is basically the movements which you can see. This is tardive dyskinesia, a very close feature of autoimmune encephalitis. Quickly, two more videos. This child, you see, this child has erratic myoclonus. Erratic myoclonus with neuroregression. So this video, if you closely observe, this child also has the random eye movements. So this child actually, whenever we have erratic eye movements and erratic myoclonus, think about opsoclonus myoclonus ataxia syndrome. So this child again, watch closely. This is opsoclonus. So opsoclonus, myoclonus, ataxia, they can come in any order, and it's a pretty dreaded disorder. You need to find an underlying neuroblastoma, treat early with steroids and other immunomodulation. I'll skip this quickly into the treatment. Depending on the type of movement disorder, you need to choose the treatment. And chorea, the treatment of choice will be valproate and haloperidol. Dystonia, typically you can use trihexyphenidyl or tetrabenazine or deep brain stimulation in the refractory. Tremor, use propranolol. Tics, use tetrabenazine, risperidone, or clonidine. So these are the typical drugs which we prefer. And surgical, I won't go into the detail. I'll just go into the quickly take home. Movement disorders in children are very complex, and you need regular follow-ups, repeated history, and home videos need to be taken to identify the phenomenology. Onset of illness is extremely important. Acute versus subacute versus chronic. Acute, think of drugs. Acute, think of infection. Subacute, think of autoimmune encephalitis. Chronic, think of SSP and other neurodevelopmental disorders and regression NBI, Wilson's. Transient, intermittent, and progressive, depending on the type of movement disorder. The movement disorder is just transient, forget about it. Don't go into the details of the etiology. Sometimes you can ignore that. Intermittent, it's going to come back. You need to think of, tics, etc. Progressive, you start thinking of a neuroregression disorder like Wilson, SSP. Once these things start, they won't stop in between. They progress. So always ask for associated manifestations like neuropsychiatric manifestations, behavioral problems, emotional lability, hallucinations will point towards SSP, autoimmune encephalitis, Wilson's, a very important movement disorder uh, accompanied manifestation. Ask for myoclonic jerks for SSP, regression, developmental delay. Parental history, primary genetic dystonias, mitochondrial and neurometabolic disorders, extremely important, consanguinity, and some genetic dystonias have autosomal dominant as well. So immediate parents also can have. History of drug intake, as I said, tardive dyskinesia, the commonest culprits are antipsychotic medications, class 1, or the typical antipsychotics. The flufenthixine, that the first class, the older antipsychotics are typically known to cause these, but the newer antiepileptics like atypical also are known to cause tardive dyskinesia. And also antiemetics. One thing I want to highlight is metoclopramide. Still, a lot of people use metoclopramide for some reason, but metoclopramide is a very commonly used drug which can cause tardive dyskinesia. And as I said, tardive dyskinesia can start after so many weeks also. For example, if you have given 3 doses of metoclopramide last week, the tardive dyskinesia can progress for the next 2-3 months also. So always consider recreational drug use in teenagers and history of some exposure to parties, etc., and behavioral problems and movement disorder. Always try to subtype the movement disorder, hyper versus hypokinetic, and then in the hyper, chorea, ethitosis, dystonia, tremor, dyskinesia. This will also give a probable etiological clue and also treatment. And the rational investigations like neuroimaging extremely important. And in some cases, you have to go for CSF if you're suspecting SSP or autoimmune encephalitis. And functional neurological disorders, never go with the misconception that every teenager who walks into your OPD or emergency with behavioral problems is not going to be a functional neurological disorder. Any teenager, any female teenager coming to you is never going to be FND. You have to rule other causes out. So labeling FND is not that easy, but if you label FND and underlying organic disorders missed out, it's going to be a very bad thing. So always keep FND or primary psychiatric disorders and pandas as diagnosis of exclusion. Try to rule out organic causes first. And rational use of medications, I quickly go. As I said, clonidine is very excellent drug in tics and in ICU movements. Like post extubation, you have a lot of type of movements like choreoathetosis and dystonia. All that are clonidine is excellent drug for that. And post extubation movement disorder also clonidine is extremely good. And in dystonia, we prefer giving baclofen or gabapentin or trihexyphenidyl. In chorea, we prefer valproate, topiramate, haloperidol, and propranolol in tremors. And never miss a movement disorder, which is a part of a systemic neurological disorder, a systemic treatable disorder. Because movement disorder is just a presentation of a bigger picture. See the larger picture. definitely do not miss autoimmune encephalitis. They have predominant orofacial dyskinesias, NMDA. Wilson's can have dystonia and other movement disorder. SSP can also have movement disorder and seizures and behavioral problems. Sydenham's chorea, OMAS, that is opsoclonus myoclonus, and tardive dyskinesia. So these are all treatable disorders wherein you identify the cause, you start treating it, or stop the drug, the movement disorder is going to be reversed. Yeah, I think I'll end here. Thank you so much. I think I can take up questions.
And a glass of water also, Dr. Jain. Thank you for the incredible presentation. I would like to invite Lokesh sir for his expert opinions and share his insight and features. It's a privilege to have him on board today for this lecture. Lokesh sir.
I think that was a very comprehensive session with lots of videos. I think very helpful for all the attendees. I think the one of the important principle is not try to fixate onto the sort of trying to fix into a diagnosis. Describe the movements and then try and see what it can mean. So if you know the definitions of the movement disorder, then if you describe it accurately, you'll be able to know what it is. So that's what we always told the trainees, don't try to think in terms of a diagnosis. Think in terms of movement, describe the movements, and then based on that, you'll be able to get your diagnosis. And then once you have a phenomenology, then you go for the treatment and the investigation simultaneously. Thank you.
So we have a question where Dr. Sameer is asking, can focal seizure occur while the child is standing and is conscious?
Yeah, very much possible. Focal aware seizures, very much possible.
The second one is a tetanus treatment. Is it curable? What is your experience? This is a question by Dr. Arti. Tetanic spasm. What is the treatment for it? If at all there is, and if at all there is extensive experience to share. Yeah, Dr. Arti would be is asking this question.
Yeah, so usually we have not seen it in last many years, thankfully, with the improved immunization coverage and the TT being given quite aggressively. But last many years back when we were training, only we have seen them. And you give a benzodiazepine as infusion and then intubate them and ventilate them to protect the airway. And gradually, some of them do come out of those things, but they might take weeks, sometimes months as well to come out of it. But some of them have developed hypoxic injury during the events. But yes, some of them do come out.
Thank you, sir. Now I would like to invite Shri Krishna sir for closing remarks.
I must say that it's an excellent, really, especially showing the videos and demonstrating it. I know that they're all cannot be taken as videos, but always we need to see them repeatedly, then only we'll understand. Even sometimes all are looking similar, and especially small child. And really excellent, Dr. Jayanth, and I thank both Dr. Jayanth and Lokesh for this excellent session and very, very useful for both PGs and the practitioners. It's very, very useful topic. And I request both of you to be in a WhatsApp group for 1 week, because this program is seen by nearly 2,000 plus doctors in YouTube, and they may have the doubts and questions. So you can take 10 to 15 minutes time on any day, on every day for 5-10 minutes, any day, anytime, and just explain if anything you want to give explanation for some of their. Thank you very much, both of you, Dr. Lokesh and Dr. Jayanth. And meanwhile, I appreciate Dr. Nitin also for doing this an excellent session in a very, very soothing manner.
Thank you, Dr. Jain. Thank you, Lokesh sir. Thank you, Shri Krishna sir, for your encouragement every time, sir. Thank you, everyone, for joining. So we will end this session, sir.
Thank you.
Thank you.
We can sign off. Thank you.